So what we're going to do is kind of talk about some of the research examining adverse childhood experiences and or ACEs, the link between ACEs and medical, psychiatric, and psychosocial conditions, and kind of talk about some really simple things that you can do in consideration of ACEs in your patients and how you might deliver care based on that. So essentially, the study started by the Center for Disease Control and Kaiser Permanente, and they really started based on this realization that they were predominantly women, but it was some men too, who were involved in these weight loss programs. And what they were finding is that the people who were losing the most weight were then dropping out. And then they were asking people, well, what is it that led you to drop out? And the people were saying something to the effect of, my obesity is protective. It feels protective. I feel safer with this weight, both from a physical prowess standpoint, as well as, not to say that weight is necessarily going to buffer you from being objectified, but culturally we tend to objectify less likely people who are obese or significantly overweight, and they're less sexualized. And then we already knew, at least the research suggested, that there's already this link between sort of trauma and addiction. So this is when Kaiser Permanente and CDC started to wonder, are some of these health behaviors people's solutions? Are they creating solutions to problems, but that are also affecting healthcare overall? So what did it examine? The initial ACEs study examined the relationship between 10 adverse child experiences and later physical mental health status as an adult. I'll go ahead and be the first to say these studies are not perfect. No research study is perfect. There's not a randomized clinical trial. Thankfully, we don't want to randomize people into a trauma condition and see how they fare. Also, longitudinal studies are oftentimes hard to pull off. They're expensive, and it's hard to put in that kind of effort. So a lot of these are correlational, and they're also they're correlational as well as a lot of times as participants who are looking back on their childhood. But what I think you'll see is that there's a really strong body of evidence with these type of studies that show this relationship between this adverse childhood experiences in later health outcomes. So there were two waves of the study. So you see, it was about 1,600 folks altogether. And the thing that was also interesting to people is these were folks with health insurance, with Kaiser Permanente. They were predominantly middle class and upper middle class. So not also people that you would have necessarily suspect would have experienced a lot of trauma. And what we'll find out is that it was much higher than what people thought. So essentially what they have found is that the more adverse child experiences that you have, it affects things like health outcomes, or it appears to affect things like obesity, diabetes, depression, behaviors, as well as life potential. Graduation rates go down, all sorts of different issues that come. And you can see from the graph that essentially the more adverse child experiences that you have, the more problematic health outcomes that are consistent with that. So what did they look at in the study? And in the research that we'll go through a little bit later, they suggest that as a primary care physician in particular, you don't necessarily have to screen for these things, but to keep your ears open and to kind of think about what's happening to your patients through their care. So what they looked at were 3 forms of abuse: sexual, emotional, physical. So, if you're working with a person, child, young adult who is involved in child welfare, you might suspect there might be some of these things on board. Neglect, emotional, physical. So those were 5 of the adverse childhood experiences. And the other 5 were all around more the family. So a mother who is in a domestic violence situation, parental separation or divorce, which can be much harder for kids than what we think. And even some of the long-term outcomes suggest that divorce can really affect negatively some folks. Mental illness in the household, substance abuse in the household, incarcerated household member. So you kind of want to think about your clients who you already know they may already have some of these issues going on, or patients, and wondering how this might be affecting them. And these are some of the rates. So about 11% of the participants acknowledged emotional abuse, 28% physical, 21% sexual. And you can kind of see from there what the rates are across these different categories of adverse childhood experiences. And And what they found, again, and this was a population of people who were predominantly middle class, upper middle class, employed with Kaiser Permanente insurance. And they found that 1 in 8 people had had 4 or more of these adverse childhood experiences. And that was really surprising to the field, who had really underestimated the effect of adverse childhood experiences or the prevalence. So this is sort of what we think happens. So you have an adverse childhood experience, and, let's just say like some sort of trauma. Disrupted neurodevelopment might be where your amygdala becomes more active, and that's in some ways very advantageous. If you're in a household where you could get hit at any point in time, it's pretty good to keep your alertness about you and keep vigilant and make sure nothing's going to happen to you. The problem with that is that you're also taking away resources from your prefrontal cortex, and other brain development suffers because of this sort of focus on vigilance. And what we also know is that can then dive into social, emotional, and cognitive impairment. For example, people who've experienced trauma are more likely to look at a neutral face and see that face as threatening. So people begin to read the world in a more dangerous way than what it really is, again, from having those experiences. And then that can lead into issues like drug use, suicidal behaviors, non-suicidal self-injurious behavior, overeating, you kind of name it. Lots of different health risk behaviors, which then, of course, leads to disease and disability and social problems, and then finally, unfortunately, to earlier death. So these are this sort of the cascade of events, and I think what to sort of focus on is that when we're in this experience of working with children, we can really begin to do some work in this disrupted neurodevelopment and the social, emotional, and cognitive development areas to try and mitigate the further downhill effects. So here's just a couple of other stories, ACEs related. One is 141 youth, 9 and 19 years old. They found a really strong connection between perceived pain and adverse childhood experiences, depression, anxiety, missed school days, and also this forgetfulness. Like kids just forgetting to bring homework, forgetting about assignments, forgetting, whatever, which of course leads to more cascade of effects with school. The second study down there suggests that the exposure to ACEs really can increase the point at which you begin using illicit drugs. So it increases by 40% during early adolescence. So just think about that for a moment, that kids who've experienced adverse childhood experiences are 40% more likely to engage in illicit drug use during early adolescence. And then finally, this was a meta-analysis of 42 studies. And all the studies found that the more ACEs a child had, the greater effect on physical, psychiatric, and behavior problems. So I think there's pretty good agreement in the field that these adverse childhood experiences do create outcomes that are negative down the road, even if you look at it from a stress hormone perspective, that these stress hormones might be present longer in the body than what they're intended to, because the person's in a consistent state of arousal. So what do you do? So I was looking in some of the family medicine literature, and really it's very consistent with the trauma-informed care literature in general, and I'll go through that very quickly. The first thing is just to appreciate the breadth the breadth of trauma. And just sort of, I think, have an appreciation that it's pretty likely on any given day you've worked with a couple of trauma survivors in your setting, even if they have never disclosed that. Secondly, trauma is very subjective. I've had people who have described horrific things happening, and it seems that they're less affected than sometimes someone who describes something I would perceive as more minor. But I learned really quickly, don't get in the business of judging people's trauma. It's very individualized, subjective experience. Assume people are doing the best they can. Again, if you think about obesity, like we just talked about, have an appreciation that for some of the folks in that situation, that's the only way they feel safe. They're doing the best they can to feel safe by intentionally gaining weight to a degree to where they feel safe, and to not disrespect that or to see that as purely ineffective strategy. Maximizing the healing power of interactions, and that's really just listening to people and wondering with a patient, how come is it, what do you see as any benefits of your current weight? What are the reasons you like eating the way that you do? and asking those kind of questions, because there's a message there, as well as some of the other messages we talked about. What are the benefits about non-suicidal self-injurious behavior? There's a hidden message there that suggests the person that you're working with has some sense. They've engaged in these behaviors for a reason, and you're ready to listen to them, which is a very different experience than you shouldn't do that, right? And also sensitive referrals, appreciating that people may not be ready for a referral, to offer it. And we've mentioned in a few of these different sessions, a call back a couple of days later really sends this message: I care about you. I've been thinking about you over the past few days, so I called you. For someone who hasn't had attachment with an adult figure, that can be really powerful to have an adult reach out and say, I've been thinking about you, I'm just wondering whether you made that referral. Respect, empowerment, collaboration, and connection with patients. And my favorite, it dovetails into motivational interviewing. Really a big argument in the trauma field that motivational interviewing should be one of the interventions to really work with, because it's got that collaborative style, and there's a lot of empathy in questioning or wondering about why the person's engaging in less helpful behaviors, or seemingly less helpful behaviors. Engage patients in organizational level decisions, and I wrote in there, why do all the magazines in the lobby have white people on the cover? Really important to think about what your lobby says to people coming in. If you serve a diverse group of people and this is a simple thing, but all your magazines have white people, there's an implicit message that your group's really not as valued here. We don't really think about as much your group here as other groups. And literally one of the things that we asked I've done this a lot, like trying to recreate lobbies to make them more helpful for people. A lot of the feedback we get is you need more diverse magazines, and we need some stuff to do while we're sitting here, like some mandalas to do some art, some interesting reading materials, and self-care to mitigate your own vicarious trauma. When you're delving into people's experiences on a daily basis and seeing outcomes that are sometimes problematic, for most of us, that begins to take a toll, and we actually become less helpful providers at that point. So it's really important to have a go-to strategy or strategies that maintain your wellness and your well-being. Some other things that this sort of gets into the SAMHSA trauma-informed care process that really grew from this line of research, realizing the widespread effect of trauma, recognizing signs and symptoms. We've talked about that in a number of the different sessions. Respond by fully integrating knowledge about trauma into policies, procedures, and practices. So that might just mean if you're a primary care physician, you understand some of the symptoms of trauma, and you understand that there's some interventions like trauma-focused CBT that could be helpful to refer folks to. And that also, just by you being empathetic to the person that you're sitting across, that alone can be helpful. And to really actively resist re-traumatization. So again, telling a patient you're really overweight and you need to stop eating and do something differently can be perceived as traumatizing to someone who has been actively putting on weight in order to mitigate other concerns related to trauma. That survivors need to be respected, informed, and connected to hopeful folks regarding their recovery. So a sense of hope. Appreciating how connected trauma and substance abuse, eating disorders, depression, and anxiety are, and the need to work in a collaborative way. There's this notion or this saying, nothing about us without us, that gets discussed in a lot of circles, but that definitely gets discussed in this circle too. Again, where you're kind of wondering from patients, more on a macro level, what's it like when you come through the door at our center? What does it feel like? What makes you nervous? What do you like? And getting feedback from people. And like I said, I've been in the business of changing lobbies. People have a lot to say about lobbies when you ask them. And that's my references there. So I think really the take-home message is to be aware that trauma is a very prevalent issue, that sometimes trauma manifests in ways that aren't expected and that can really affect people's health outcomes and health behaviors. And therefore, it's important to have, as best you can, kind of an understanding and empathy for how the person got into the situation with this health behavior, and to take a positive, hopeful approach around that. And to be prepared to refer people to trauma services as necessary. So that's my spiel.
So it makes me think